Hi there. Happy Heart Health Month from Gynecology. This is Dr. Maria Sophocles, and this is an episode of Gynecology. And February is a month when I always think about my heart and the hearts of my family and those I love and all my wonderful patients. And um, even though I'm a surgical specialist, I feel like every physician and every kind of physician should be thinking about the heart health of their patients. And this is because heart disease kills more women than pretty much anything. It's the leading cause of death among women in the United States, more than cancer, which is number two. This is not for every race, so I do want to clarify that a little bit. For Hispanic and Asian women, cancer kills more women. But for African American and white women, it is the leading cause of death in the US. So I think it's important to address it. OBGYNs are a kind of funny hybrid of surgical specialists and primary care. And so when we wear our primary care hats, I think we are compelled to screen and make sure every single patient, actually at every age, is thinking about their heart health. We know that there is an enormous gender discrepancy in terms of diagnosing and treating cardiovascular disease in the US and globally. A woman with chest pain going to the emergency room is much less likely to be correctly diagnosed as having cardiovascular issues, much more likely to be considered having chest pain due to stress, anxiety, or gastrointestinal reflux, something like that. So it's really important that women take care of themselves and know to advocate. So part of this starts with understanding one's risk factors for cardiovascular disease. Risk factors for development of cardiovascular disease are as follows: high blood pressure, high cholesterol, smoking, diabetes, being overweight or obese, consuming an unhealthy diet with saturated fats, and we'll get into that, but more specifically, mono unsaturated fats, physical inactivity, and frequent alcohol use. These are not surprises to most people. Most people have heard this ad nauseum. So the problem is, why don't we really pay attention? Why do we still end up um, developing heart disease? And I think some of this comes from our messaging. We think of heart disease as a male disease. We picture heart attacks on ads for statins and in Hollywood as something that happens to men clutching their chest and then succumbing to a heart attack. As many women as men die of heart disease. Let me say that again. As many women as men die of heart disease. So we can't neglect, the women who are hopefully watching this show, can't neglect the fact that we are as likely to have heart disease as a man. Heart disease starts when we're young, and this is also a really strange concept for people who picture a heart attack as something that happens to older people. Well, that may be true partly in that many people who have heart attacks don't have them until they're middle age or older. But a heart attack is often something that is the final result of something, a process that has started decades before. And I think that's what I want you to understand tonight is that atherosclerosis, the process by which plaques build up in our arteries, is not something that just happens in our 60s and 70s. This happens in our teens and our 20s, and then begins to build upon itself in our 30s and our 40s and our 50s. And so we can, from a young age, make changes and make decisions that will impact how healthy we are in a cardiovascular sense in middle age and in old age. I think it's also super important to realize that 1 in 200 people have a genetic predisposition to very high cholesterol. This is silent. You wouldn't know it. You'd never know it to look at that person. That person may be you. It may be someone who's thin, who's fit, who's active, who's a non-smoker, and yet their body is not metabolizing cholesterol at the same rate. And so their cholesterol is higher even as a child. So I'm a patient with something like this. It's called familial hypercholesterolemia. And again, 1 in 200 people is not so rare. So if you have a family history of uncles or aunts or grandparents who had heart attacks early, say in their 40s or 50s, do not just chalk that up to really bad luck for them. Think about the fact that those relatives may be sending a warning signal to you, and maybe they had high cholesterol all along, and that culminated in our coronary artery disease at an earlier age and a heart attack at an earlier age. So even if it's your brother who had a heart attack at 48, consider that significant. Consider that your problem as well. And make sure you ask your gynecologist or any clinician that you go to whether you could get a fasting lipid panel, a cholesterol test to look at your good and your bad and your total cholesterol. Good cholesterol is called HDL. It's protective against the development of coronary artery disease. And in women, we want that good cholesterol to be 50 or over. So HDL is good cholesterol. LDL is bad cholesterol. And LDL, and this is important, you want to be between 80 and 100. Many of my patients come to me and say, well, mine's 125. It's not that different. Actually, that's about 50% over the target of 80 that you want to achieve. Many physicians still use the old number of 100. Try to get your LDL down to 100. But I believe, and I was lucky enough to work with cardiology researchers, and the real goal for women should be 80. So if you can get an LDL closer to 80, that's much better. Can you do it just with diet alone? Maybe, but you may need help with medication. So many people say, well, I don't want to take medication. Well, none of us want to, but none of us want to die of heart disease either. And the medications available for heart disease are super well studied and super safe. I'm talking about statins like rosuvastatin and atorvastatin. It's a family of medications. There are many, many statins on the market. They've been well studied. They're not without side effects. You can develop side effects, but not really dangerous ones, just annoying ones. In comparison, people who remain hypercholesterolemic and allow their arteries to, at an accelerated rate, make plaques are a setup for a heart attack or a stroke. So I can't stress enough how important it is for you to know your own cholesterol levels, to know what are nice normal levels, and to advocate for yourself, because you may have a clinician who's a little more passive about managing cholesterol. And especially in women, I've had many women say that their family doctor is very aggressive about making sure their husband has his cholesterol in check. But in terms of the wife's cholesterol, they just say, look, call me if you have chest pain. That's not okay. That's never okay. So advocate for yourself. So let's talk about some of the other risk factors. We mentioned cholesterol, but blood pressure is another risk factor. If you have elevated blood pressure, that is strain and stress on your arteries, and it can contribute to a heart attack or development of artery disease. Now, what about if you don't really have high blood pressure, but you did have high blood pressure in pregnancy? Does that count? The answer is yes, we think so. We think that pregnancy is a sort of sneak peek or a window into what your cardiovascular system will be like as an older woman. High blood pressure in pregnancy, one type of it is called preeclampsia. There are several types, but if you had high blood pressure in pregnancy, consider yourself high risk to develop high blood pressure later in life and an elevated risk to develop cardiovascular disease. What can you do about it? You can compensate for it by being thin, healthy, active, and having a clinician who takes you seriously and keeps all your numbers in check. Um, Speaking of numbers, we live in a society that prizes beauty and health, and thinness is very touted. I don't want anyone to think that necessarily being thinner is better. Some women can be too thin, and being too thin can be unhealthy. But we know that being severely overweight can also be unhealthy. It can be stress and strain on the heart. It makes the heart muscle work harder, and it can contribute to heart disease and having a heart attack. Along those same lines, we know that inactivity is a problem. Why? Because we need to be active. We need to have muscle mass and muscle tone in our bodies to burn appropriate calories. And we need to keep the heart strong. The heart is a muscle, so it needs to be worked and exercised just like an arm or a leg. And inactivity is a recipe for a heart that's not in shape, if you will. So those are risk factors for heart disease in women: blood pressure, cholesterol, obesity, inactivity, um, uh, excess saturated fat in the diet, physical activity, and then alcohol use is the one I hadn't yet mentioned. We know there's a link to alcohol use and development of fatty liver, and also coronary artery disease. So alcohol in moderation seems to be fine. In fact, limiting alcohol use to 1 drink per day, 1 drink meaning 1 beer, 1 glass of wine, or 1 shot of hard alcohol, seems to be all right. But more than that, you begin to associate with negative health effects. Okay. Um, I'd like to talk about the fact that many women have atypical presentations of heart attack or cardiac events. And this is one problem. So, women are more likely to present to an emergency room than men with chest pain linked to emotional stress. So that is a problem because then they are dismissed. The ER clinician says, look, you had a fight with your husband. Look, you had a fight with the taxi driver. Just do some deep breathing and meditation and you'll be fine, lady. You've just had a stressful day. But that stress, despite the fact that it's sort of confusing to the picture, when combined with chest pain, can truly be a symptom of coronary artery spasm and heart attack. So do not let chest pain associated with stress be brushed off. Take that seriously. Go to an emergency room and get it evaluated. Women are also more likely to present to an emergency room with back pain when they were having a heart attack. And most clinicians do not link upper abdominal pain or back pain to a heart attack. And so when women present with this, again, they may not be given the opportunity to have EKG monitoring. So do not be brushed off and told your back pain is nothing. Make sure that the EKG is done and that it's normal. Another atypical symptom is nausea. Women will develop nausea. Why will they have nausea, vomiting, or fatigue? Well, if they're having a heart attack, the blood is shunted away from the stomach to try to help the heart. So if the blood isn't getting to your stomach, especially if there's food in there, you may have nausea and vomiting and not be able to process or digest the food in your stomach, and you may in fact become nauseous and vomit. So these are atypical, and some women will stay home or will brush it off as nothing or think it will pass. Minutes and seconds count. If you're not sure, call 911 or go to an emergency room. It's not worth waiting around to see what's going to happen, because if you have a blocked artery, that can be helped quickly. You can be rushed and have a catheterization and a stent placement. You can be given medication to dissolve that clot, but it must be done in a timely fashion. So beware, women listening, that your heart attack may not present in the stereotypical crushing chest pain where patients say it feels like an elephant is sitting on my chest. It might, but also you could have pain in the back, you could have pain in the neck or the jaw, you could have pain in your throat, you could have pain in the arm. Pain down your left arm is quite classic. So pain in the neck, the jaw, the throat, the back, the arm, these all count. And especially if they're accompanied by chest pain that is tightening or a crushing or pressure feeling, don't wait. Get help. So angina is a word maybe you've heard of. Angina is a word to describe chest pain, either a dull pain or a pressure. Some people describe it as sharp. Most people say it feels dull and heavy, like pressure on their chest. Some people will develop angina with exertion. They're doing their usual bicycling or exercise and they push it a little too far and they get angina. If this is you, get to a doctor. A doctor can do a stress test or other evaluations to see if under exertion, the heart doesn't handle that well and develops pain. You may have blockage in one or more arteries, in which case, again, you may require a stent, you may require coronary artery bypass grafting or CABG, CABG procedure. I don't mean to get morbid, but I think it's important that you think about the reality of this. I've had too many patients tell me they were experiencing angina, but they really were just busy or weren't able to remember to get to the doctor because they were taking care of their sick mom or their child. Women are notoriously bad at taking care of themselves medically. So again, please advocate for yourself. February is a great month to prioritize your heart health. An easy mnemonic is the ABCs of heart health. So ABCs: A, aspirin; B, blood pressure; C, cholesterol; and S, smoking. Let's go back to those. So A, take aspirin when appropriate. Well, there's two ways to take aspirin, and the the first is a little bit controversial. Okay, baby aspirin is something and that has been used to prevent the development of coronary artery disease, and this works through platelets. Okay, aspirin can prevent platelet aggregation, and platelets are a component of an atherosclerotic plaque. So people who take baby aspirin have been shown to have a reduced development of an atherosclerotic plaque, especially a kind of hard, dense plaque that then can rupture and cause a heart attack. The data has been mixed. There have been studies showing baby aspirin does not make a difference and does not help, and other studies have shown baby aspirin helps in certain populations. If you're not sure, or you're not sure whether you fit into one of the at-risk populations that would benefit from taking a baby aspirin every day, you should ask your primary care physician. If they're not sure, and they might not be, and that's okay, seek an advice of a cardiologist, specifically a preventive cardiologist. The University of Pennsylvania has a department of preventive cardiology, which is excellent. And you're always welcome to contact me at princetongyn.com or 609-430-1900 and see if you can get that information from me, or just look up University of Pennsylvania Department of Preventive Cardiology. Anyway, a cardiologist, especially a preventive cardiologist, will be able to tell you whether baby aspirin every day is right for you. I know I take it. The other time that we take aspirin in relation to heart disease is an acute experience. If we're at home and feel we're having a heart attack, you can call 911, and if you have not baby aspirin, but full strength 325 milligram aspirin, you can put that under your tongue, start to dissolve it while you're waiting for paramedics to arrive. And studies show that is beneficial. So again, baby aspirin can be taken every day in a preventative way, but full strength 325 milligram aspirin can be taken acutely if you're experiencing symptoms of chest pain and you're worried that you could be having a heart attack. Baby aspirin's 81 milligrams. A full strength aspirin is 325 milligrams. So those are the two times when aspirin may be truly life-saving. The B is blood pressure. We talked about that a little bit already, that you want your blood pressure controlled. You want the top number under 140 and ideally under 130. You want the bottom number under 90. So again, if you can get your blood pressure under 140 over 90, that's ideal. Low salt diets, and removing salt from your diet or restricting salt from your diet is one of the first things doctors will recommend to lower your blood pressure. If that's not sufficient, they may put you on antihypertensive medications, and that's a huge subject for another time. C, so A, aspirin, B, blood pressure, C, cholesterol management. We discussed this already. We want your LDL, what? 80 to 100. So 80 to 100 LDL. I think that's the single most important thing you can probably do is know your LDL, make sure it's in that range. And then S, so ABCs, the ABCs, don't smoke. Smoking has so many links to so much pathology, it's not even funny. So we all know that smoking links to lung, bladder, and many, many cancers. But you may not think of smoking as also linking to and accelerating coronary artery disease. Well, it does. It also destroys very fine blood vessels, so it helps destroy circulation in your peripheral extremities, your hands and your feet. So don't smoke. If you smoke, try to quit. If you need help quitting, talk to your doctor. There are great strategies for quitting now that we can use. I think that I'm going to kind of keep it short and sweet. If anyone has questions, you can ask them. If you don't have any questions, but you just want to talk more with me or any other clinician at Women's Healthcare of Princeton, please reach out to us at Princeton GYN. We would love to help you get started on your journey to heart health. And there's no time that's too late. It's never too late. Even if you've had a heart attack, it's never too late to have proper rehabilitation and protect the heart that wasn't damaged. It's never too early. If you think you're 20 and 30 years old and there's no way you have to worry about heart disease, you're wrong. You should check your cholesterol. You should know your cholesterol. I've had 20-year-olds who've come in, we've talked about their family history, we've checked their cholesterol. It was sky high. Of course, they felt fine. And through them, we did something called cascade screening. We checked all their family members and found high cholesterol throughout the family. So you can be the agent of change. You can be the one, even if you're only 20 or 30 years old, to educate and empower your own health and that of your family. I can't say that enough, that no matter what your age, it's never the wrong time to think about heart health. I've had the misfortune of knowing many wonderful people who had heart disease but just didn't know it, or had chest pain but were brushed aside, often because of their age or their gender. I myself have gone to a cardiologist knowing I had genetically high cholesterol and was told, well, you're thin and you're active and you're young. Oh, and you're female, so estrogen will protect you. You'll be fine. That's ignorant and wrong. Estrogen is protective, and this is why premenopausally women have fewer heart attacks than men, but postmenopause, they have just as many, if not more. So please don't rely on that. Please make sure you take care of yourself and that your doctors are taking you seriously. I think that's about it. I'm going to wrap it up a little early because it's February, and it's Heart Month, and this way I'll give you guys time to go and search some of the great YouTube clips out there on women and heart disease. Yale Medicine has a nice one. And anyway, I look forward to seeing you all in a few weeks for the next Gynecology. Remember, this is Dr. Maria Sophocles, and I'm a physician at Women's Healthcare of Princeton. Our website is www.princetongyn.com, princetongyn.com, and you can subscribe just by typing gynecology and searching that on the web, gynecology.princetongyn.com, or search for us on YouTube or Facebook. We love educating and empowering you, and we look forward to another topic and to seeing you soon. Take care and have a great night. Bye-bye.